Well, welcome to this video. Now, I was going to report on this new vitamin D clinical trial. Yes, that's right, vitamin D clinical trial, along with some news today, but I started prepping it and it's such an important data set, such an important result, I've decided to do the whole episode on that. So to give you the bottom line is the first randomized blind controlled trial on vitamin D as an interventive therapeutic in poorly people has been published, and the results are more positive than I could have imagined. That's the bottom line of this video. Now, what this really makes me think about is, I've been talking about this since January. Many reputable scientists have been talking about this, but governments and agencies seem to have been putting it down. Now, I'm not a conspiracy theorist, but this stuff's readily available and it's cheap, and it really isn't a problem. When I say cheap, we can manufacture this, or pharmaceutical manufacturers can manufacture this for essentially nothing. And yet more expensive drugs are being used. What's going on here? Why has there been no organised clinical trial by the World Health Organization, the Oxford Centre for Evidence-Based Medicine, the Centres for Disease Control? There's so much evidence now for vitamin D. Why is this not being done? It really is quite strange. Now, enough speculation. Let's dive straight into the facts. Now, just by way of background, as we've looked at many times on this programme, this is data from Healthline, readily available. Click on that. I did it this morning. Takes you straight through. And we see that 42% of the population is deficient in vitamin D in the United States. But in certain ethnic groups, this raises dramatically. And of course, these are the groups from memory that have 4.7 times higher death rate than the European descent population group. So vitamin D deficiency, very prevalent in the United States. And we could spend the whole video giving information from other countries that would show very similar results. Now, just to give you an example, this was published on the 3rd of September. This is not the main study, but there's so much of this sort of studies now. So many like this. I'm just going to give this as a quick example. 3rd of September. Journal of the American Medical Association, reputable stuff, based in Chicago, association of vitamin D status and other clinical characteristics with COVID-19 test results. So what this group did was they took people who'd had vitamin D tests in the year before and worked out whether they were deficient or not. And then when they came into hospital and tested positive for COVID-19, they did a correlation study on it to see if there was any difference between those that were deficient in vitamin D and those that were not deficient in vitamin D in the results taken in the past year. So in other words, these were patients that they already had vitamin D status data on. So yeah, very, very sensible approach. Nothing wrong with that at all. They got a cohort of 489. So in this hospital, it's a single centre study. It's not a perfect study. So they happened, for the people that were admitted, there was way more admitted with COVID-19 than that, obviously. But they had vitamin D status on 489 of those people. So patients who had vitamin D levelled in the year before, so the year before COVID-19 testing, before people tested positive for COVID-19. And the relative risk of testing positive for COVID-19 was 1.77 times if you were deficient in vitamin D. So people that were short of vitamin D in the previous year weren't twice as likely to get COVID-19 or be diagnosed with COVID-19, but they were 1.77 times. Now, if there'd been no difference, that would have been 1. So 1.77 times more likely to be diagnosed with COVID-19 if they were vitamin D deficient in the past year. Not a clinical trial, but pretty impressive. Now, this is not so much people that are tested positive for COVID-19, remember. This is people that have tested positive for COVID-19 having come in to a hospital facility. So these were the people that were more poorly. So what we can actually say is there's a 1.77 greater times chance of being admitted if you're vitamin D deficient and receiving a positive COVID-19 diagnosis. Now, I could have quoted many similar studies. I've just quoted that one because it's the most recent one I could find. Perfectly legitimate correlation observational study. But of course, we need clinical trials to be definitive. The World Health Organization has been going on and on and on about the need for clinical trials quite rightly, but it has not organised a clinical trial on vitamin D status and infection, let alone COVID-19 status. It really begs the question, why not? And I would love someone from the World Health Organization to get into contact with me and tell me why not. Or the Centres for Oxford Centre for Evidence-Based Medicine, or the Centres for Disease Control. Just why isn't this being done? It just you sense my frustration. This is the trial. Published, it's work done in Spain, published in the Journal of Steroid Biochemistry and Molecular Biology, reputable journal. Not everyone's heard of it, but quite a lot of stuff's published there. Therapy versus best available treatment. Right, so what they did was, they had people coming into this study in Spain, and one group, they gave them the current best available treatment as per their hospital protocols. The other group, they gave them the best possible treatment as per their hospital protocols, plus additional vitamin D, or a form of vitamin D, as we'll see. So it's quite simple. Standard treatment without vitamin D, standard treatment with additional vitamin D. Now, surprisingly, this is done in Spain, which, of course, I mean, you know, most of us in England or wherever go to Spain to get a suntan. But in these parts of Spain, it's not really cultural to go in the sun. So people, surprisingly enough, in these areas are relatively vitamin D deficient. Surprising, but true. Right, let's dive straight into it. The objective of the study: does vitamin D decrease acute respiratory distress syndrome, which of course is the filling up of the alveoli with the inflammatory fluid so people can't breathe, as you know. The acute respiratory distress syndrome, which is the inflammatory complication that kills most people in COVID-19. And what they wanted to test for was the effect of calcifediol. Now, calcifediol is the same as 25 vitamin D, is the same as 25 hydroxyvitamin D. Now, what this calcifediol is, it's a drug. We use it regularly for other conditions. It's a vitamin D analogue. Now, when you take vitamin D tablets, or the skin makes vitamin D, it makes it in this form of calcifediol. But this is not the active form. It has to go to the liver to be activated into this 25 hydroxyvitamin D. Then this 25 hydroxyvitamin D has to go to the kidneys after that to be further activated into the active form, which I think is 125 dihydroxycholecalciferol from memory, but don't quote me on that. Anyway, so there's these stages of metabolism. Now, the point is, if you take vitamin D tablets, so when I take these vitamin D tablets here, if I take one of those today, it's going to take a few days for my liver to metabolize that, especially if it's a large dose. It's going to take a few days for my liver to metabolize that into the active form in the blood. So what this group is doing is they're giving it as the active form. So this calcifediol is the active form. It's already activated, so it cuts out the liver stage of activation. In other words, it increases the 25 hydroxyvitamin D levels almost straight away. It's got virtually 100% absorption from the gut. It's just given orally, and they go up straight away. Whereas if you give me a handful of these, my vitamin D levels will go up, but it's going to take time. And of course, these people were already acutely ill, so they gave this vitamin D analogue. You've got exactly the same effective increased blood levels if you're given this in higher doses the week before. But of course, these people didn't know the week before they were going to get critically ill. The implications for prevention, though, are of course obvious. The outcomes. So they gave this calcifediol because it would rapidly increase the 25 hydroxyvitamin D concentrations in the blood. So the blood levels will go up quickly. So instead of the blood levels, imagine that's blood levels there. That's the blood and that's the plasma levels. And this is a week's time. So that's days 1, 2, 3, 4, 5, 6, 7 days. So normally if you give the vitamin D, the level will go up slowly like that. But if you give it in this form of calcifidiol, the level will go up really quite quickly like that. So that's the aim, to get the rapid therapeutic plasma concentrations quickly. Makes perfect sense. But it's still vitamin D. It's a vitamin D analogue. It's not some clever different drug. The outcomes are intensive care unit admission and mortality. And there were Spanish patients, of course, because it was conducted in Spain, and they were hospitalised. So these patients were hospitalised. When they were admitted to hospital, they were given the dose of this vitamin D analogue. They were given this dose of, I get my names mixed up with this, complicated, calcifidiol. They were given the calcifidiol straight away as soon as they were hospitalised. And the question is, if they were given that as soon as they were hospitalised, would that reduce their chances of deteriorating to the point where they had to go into intensive care? Would that reduce their chances of deteriorating to the point where they would die? That is what this study is about, and they compared it with the group that were not given the vitamin D. And allocation into each group was randomised. This is a proper clinical trial. This is exactly what we need. So it's a parallel pilot. So they admit it's a pilot study because the numbers weren't very large, but it was randomised. It was double masked. That means double blind, and it's a clinical trial. So the patients came in, they were recruited into the trial, and then they were allocated into the vitamin D group or the non-vitamin D group. It's and then they saw the results from that with the vitamin D. All the other treatments were the same. Well, the results from that, and then they could compare these two sets of results, and that is, of course, is the basis of a clinical trial, as you know. So the setting was a university hospital in Corbera in Spain. Participants. Now, the numbers were small, 76 consecutive patients hospitalised with COVID-19 infection who came into hospital. Relatively small number, but we'll see the data is significant. And with this level of clinical trial, they make their point very convincingly, as we'll see. Clinical picture of acute respiratory infection. So people came in with acute respiratory infection as a complication of COVID-19. Confirmed by radiographic patterns of viral pneumonia, which of course, as we would expect with COVID-19 infection, viral pneumonia, because it is a virus, it does cause pneumonia, of course, which is inflammation and infection at the level of the alveoli. All patients received a positive diagnosis. So far, so thorough. The procedure, all hospitalised patients received best available therapy. Now, this is the ethical point about this. This was done ethically in guidance with I think it's the Helsinki principles that describe